Hi, I've been unmuted, I can see. So can you hear me okay?
We can.
Great, excellent. I'm terrified the technical side of this is all going to go badly wrong, so apologies for that. And thank you for the introduction. I think it's David that was speaking. I can only see little bits of each of your faces, so I have no idea who will be speaking. So thank you very much for inviting me. I'll try my PowerPoint up now, and let's just see if you actually can see it. You should just see my slides come up in just a second when the computer decides it's going to do that. There we go. So you should just see a slide rather than any notes. Is that what you're seeing?
Yeah.
Super. Okay. So thank you very much once again for inviting me to speak. I will try and stick to my allotted time of 15 minutes. You have asked a very big question for me to try and answer. And the question I was posed was a UK perspective. Now, I think it would be awfully presumptuous of me to say that I could speak for the entire of the UK. That's why the UK is in brackets, not because we're in some state of turmoil with Brexit, obviously. So I would caution you that it's very difficult to give a UK-wide perspective, and I think you need to keep that in mind. This is my perspective based on data that I may or may not have collected, and I'll be talking more broadly about that in a moment. So just some disclosures. I have no commercial funding. I have some positions onto professional societies that you can see there. I have had funding from the following public or professional bodies, as you can see listed there. And some of the work today, presented today, was the work related to the deep study was funded by NIHR, which is our equivalent of NIH in the UK. And obviously the views I express are those of myself and not of the NHS, NIHR, or the Department of Health. So those disclosures said, let's get into what I am going to talk about. I appreciate you've all defined things in the last day or so, but just so there's absolute clarity about what I am talking about when I refer to the catch-all term of TMD, I'm going to refer back to that. I'm going to explain the healthcare system that I work in and the perspective, and then I'll look at the evidence on the care pathways for TMD in the UK and the evidence more broadly on management, and suggest some ways forward that we could look to trial rather than that are a definitive piece of evidence. So briefly, very briefly, what are we talking about in terms of the condition? Well, we're talking about a collective term, and there's lots of pseudonyms over the years. We're talking about an often painful condition, and the 12 most common types of this painful condition are listed on the slide as defined by Schiffman et al. In 2014, and I'm sure you're all more than well aware of that. But when I refer to TMD in this presentation, it is those conditions I am referring to, not something such as a tumour growing on the side of the temporomandibular joint or some occult pathology. Just interestingly, these are data from the deep study. What is its impact on general quality of life? So that is quality of life every day, not oral health-related specific quality of life. The scale that this is showing you here runs from 1, which is perfect health, so 1.00, which is perfect health, to 0, which is a state of death, to negative 0.59 as its lowest possible score as a state worse than death, if such thing can exist. And what we found in persistent orofacial pain, with the majority of that being musculoskeletal in nature, was that actually it came in at 0.69. If I then give you some examples either side of it of conditions that are possibly more prevalent, like diabetes and depression, you can see it exerts a significant impact on day-to-day general quality of life. What about the healthcare system that you've asked me here to talk about and how it cares for people? Well, just so that we can set it in context, our total population in the UK is similar to that of Texas plus California. So we are not as big as you, and that may make things a little easier for us. We also don't have that much private healthcare in the system. We have about 10% of our population are insured with medical private health care. And as you can see, 3 million people have some form of dental benefit plan. Now, why is that? Well, that is because of the National Health Service, which is free at the point of delivery for hospital-based care, that's dental or medical, and general medical practitioner care in the community. And for some, general dental care is also free. It's means tested, however. So that leaves some people ending up paying a contribution to their dental care, and the maximum cost of a course of treatment, so to get you dentally fit at that point in time, would be £256.50 US, $337. co-payments on prescriptions, and they come in at about £8 or $11 per item on the script. So if you had 3 items that were all different items, you would pay $33 for that. Are there advantages to this centralized system? Probably, because we have centrally driven processes for education, care and governance. And 2 good examples here are the General Dental Council, which is our licensing body for all dentists, covering that whole 66 million population, as opposed to a state-by-state licensing system like you have in the USA. So that allows one message to come out from one licensing authority. We also have National Institute for Health and Care Excellence, which sets our ability to do new procedures or new medicaments centrally, and it assesses the evidence base for that. The reason I mention these 2 bodies is because the General Dental Council includes temporomandibular disorder on its curriculum by name, and its standards for professional care direct all dentists in the UK to the evidence-based or accepted reputable authorities. So that would be accepted professional groups such as the Royal College of Surgeons and other bodies like that. The National Institute for Healthcare Excellence guidance on TMD, there are 2 areas where it does provide guidance. One is what's called a clinical knowledge summary, which is a very helpful thing for general dental practitioners and general medical practitioners to access freely. Specifies reversible conservative management must come first in TMD before any other intervention. And the other piece of guidance that NICE brought in was they reviewed the evidence on total prosthetic replacement of temporomandibular joints, and again specified the same thing, unless there were demonstrable pathologies such as a tumour or the condylar head had resorbed away through, say, for instance, advanced rheumatoid arthritis. They also mandate that all total prosthetic temporomandibular joint replacements in the UK must go on a centrally held registration in a registry that's held by the British Association for Temporomandibular Joint Surgery. So there's some advantages to a centralised system, and everyone is well aware the NHS is not a panacea for all known ills, no pun intended, but it does have some advantages because it is so centralised. However, as I'm about to go on to show you, that the care pathways in orofacial pain and temporomandibular disorder in the UK are far from ideal. There are 2 types of data available on the care pathways in the UK, one of which you'll be more than familiar with, which is quantitative data, so hard facts, figures and numbers, and the other of which are qualitative data, where patients or professionals are interviewed up to the point that there are no new ideas or themes that come from those interviews. So they're asked about a particular thing that they have experienced, for example, how they have travelled through care in the UK or how they experience their TMD, and repeated interviews are conducted until there are no new ideas emerging from those interviews. So if we look first at the qualitative data and the perspectives from the UK, when we looked at this over the last 12 years or so, the professional perspectives on temporomandibular disorder is that they have a very heavy focus on reversible therapies first, which is consistent with the direction from our licensing body and consistent with the direction from NICE. But they do tend to focus on biomedical interventions, especially in primary care. And when I talk about biomedical interventions, I mean splints over and above, say, education and self-management. The primary care physician or general dental practitioner tended to articulate a large concern about managing TMD on the basis of they were worried about a misdiagnosis, that they had misdiagnosed a mimicking pathology, something pretending to be TMD, and then they begin a course of reversible treatment, and it turned out not to be TMD. They also struggle to interpret the evidence base, as I'm sure that you have heard already and are aware of in the USA and around the world. There are lots of charismatic champions for different types of therapy, and that can make it very difficult for practitioners to pick their way through that evidence base. When we spoke to patients, we found that they felt that they lacked a diagnosis and could end up in a liminal state. That is to say that without that diagnosis of this is what is causing your pain and your problems, and a label for that problem that they were experiencing, they were neither truly healthy nor truly ill in the eyes of their nearest and dearest, because they didn't have that label. And searching for that label also had a degree of stigma associated with it in their perspective, and caused them a lot of psychosocial distress and also, understandably, they had ongoing pain, which ended up continuing to cause negative impacts in their everyday life. If we then look at the quantitative descriptive data, there was some work done by my colleague in Leeds, Michelle Agrawal, and he showed that in a survey of over 200 general dental practitioners, they could diagnose a case scenario of temporomandibular disorders without a problem. And it triangulated with what we had qualitatively from the data from my team, and they also, when they responded to the case scenario, over 2/3 of them managed that initially with a stint. And referral was commonplace. So only 9% of those responding to the survey said they wouldn't refer for a specialist opinion, and they chose a TMD specialist opinion, but unfortunately in the UK there is no such specialty in TMD. The DEEP study, which is the study that I ran over 5 years, finishing only 2 years ago, was a prospective cohort and cost analysis study. We just observed the care pathway. We did not intervene within it for 24 months for each of the patients that were on the study. 240 began the study, just less than 200 ended the study, and every 6 months we looked at their quality of life, the costs they had incurred, the healthcare that they had used, and their pain-related disability. And the cohort was a mixed cohort, but 68% of the cohort had a musculoskeletal pain, therefore was likely to have TMD. So how much did the care cost the healthcare provider? This is direct costs of healthcare provider, the NHS. So up the y-axis is the mean costs in sterling, and on the x-axis is the time points. And what you'll see is if we put in appliance and intervention, which is in red, and medication in blue, you can see those costs are fairly low, maybe rising a little towards the end of the time points, but not statistically significantly. If I then add in what it costs in consultation, you don't have to be a statistician to see that there's an enormous difference between the consultation cost, that is going to see people to try and get a diagnosis, and the actual treatment costs in blue and red. And they made up almost 4 times greater the cost of any other part of the direct costs of the healthcare pathway. Why was that? That was because people were looking for a diagnosis and were being referred perhaps from a general dentist to their general medical practitioner, to the neurologist, to oral maxillofacial surgery, etc., etc., etc. So there's a bit of a circular pathway going on. And you can see that the total costs largely mirror the same pattern as the consultation costs. The consultation costs were the significant driver of healthcare costs and also the significant driver of healthcare utilisation for the patient. How much did it cost the patients? Well, unsurprisingly, because it's a centralized free at point of care delivery, there were very low costs here because these were all related to small amounts of private interventions that the patients had sought out in terms of getting to consultations in time of travel or having treatment and assessment. How much did it cost the employer? Because obviously when patients aren't well, they may be at work or they may be away from work. A lot of the work that has concentrated thus far was on absenteeism, that is being away from work. And you can see that per 6-month period, that cost was very low to the employer, £174 per 6-month period. However, when we looked at what people lost in terms of the quality of work and the quantity of work that they could do when they were at work with ongoing pain affecting their face, you can see they were losing around an hour per day in both quality and quantity. When you added this to salary, you can see that the presenteeism cost, i.e. being at work but being unable to function as well as one might be able to if one didn't have facial pain, was quite substantial in the 6-month period to the employer. And this is an unseen or hidden cost to the employer. If we take all of those costs and put them into a Markov model, and I simply do not have time to go into the intricacies of this, you can model how this comes out over an individual's lifetime. So they may have low pain disability, they may have low amounts of pain that doesn't disable them in everyday living, or they may have high pain disability, i.e. they have a lot of disability and can't function very well with a lot of intense pain, and they could transition between those states, and they could stay in those states. And obviously, eventually, everyone dies, and that would be against the national mortality statistics. But using the deep data, we could model this to say, what do we get out of giving our patients the current care pathway? If we take a patient from age 25 to the time that they die, it would cost about £24,000 to provide the care on the current care pathway. And it would only provide 17 qualities. Now, qualities are quality-adjusted life years. One quality-adjusted life year is one complete year in the complete state of health. So for our £24,000 worth of healthcare expenditure, we were gaining someone from the age of 25 until the age of death, 17 years of perfect health with our care pathway. Evidence on management is limited, and that's why you have two position statements, one from the NIHR Technology Assessment Conference and one from the American Association of Dental Research, saying that conservative reversible therapies are the first point. Why are those statements there? Well, that's our obligation to do no harm and not against the poor quality evidence base and a good success rate with reversible non-invasive therapies. It seems very sensible to start that. Recent data on self-management from Karen Raphael at NYU and myself in the UK suggests that the self-management techniques are probably more effective, and the problems with defining them and the behavioural constructs with which we use, to perform self-management are now being ironed out internationally, led by myself. Why do we need to look very carefully at prospective and trial data on surgical approaches versus reversible? Well, that's largely because most of those data show positive results for the majority who have reversible treatment and limited progression of their condition. That's not to say no one would benefit from earlier invasive intervention, but largely we can't predict who would benefit, who would worsen, and who would stay the same. So in conclusion, realistically, we need to get the basics right and build it from there. We need to improve diagnosis in primary care, allied to a better understanding and utilisation of self-management. We need authoritative patient and professional education so that there is a single voice that patients and professionals can turn to get a sensible answer on TMD. We need stratified care, and simple things like the graded chronic pain scale, which allows us to look at pain-related disability, have been proven by myself and others in recent years to provide that opportunity to fast-track those who are in most need to specialists joined up multidisciplinary care, providing earlier intervention. And data from your own country also indicate that earlier intervention is far more effective. Thank you for your time.
Thank you, Dr. Durham.